Okay, so we are recording today's session. So welcome, everybody. Welcome to the Aging Together Regional Coalition. My name is Ellen Phipps. I'm with Aging Together, and it's my pleasure to introduce our two presenters today. And before I just go ahead and do that, just a couple of housekeeping and logistics. So the first thing is if everybody could mute themselves, please, that really helps provide the best sound quality. If everyone is muted, that really helps with the presentation. So we'd appreciate that. And then there's a lot of information we're going to get through today. And so if you could hold any questions that you have, maybe jot them down, but hang on to your questions. We have two presenters. We'll hear the first presenter, and then we'll have some time for questions, and then we'll hear the second presenter, and then have some time for questions. So we'll do it like that. And now we're going to go ahead and get started. So today, we're going to hear from Lisa Dodson and Kathy Walker. Kathy is with Rappahannock-Rapidan Regional, Rappahannock-Rapidan Community Services Board. Say that 3 times fast. Okay, people are still coming in here too. All right, and Lisa Dodson, who is with the Harbor at Renaissance. And they are going to be talking about transitions in care, paying for care, how all this complicated stuff works. There's many layers. And actually, one of our board members, Christy Ludlow, actually heard this very close to this presentation live and in person, I believe, in Rappahannock County. And she was so impressed with the breadth and depth of knowledge and information. She got real excited and she told me all about it. And we agreed that it would be perfect to share with all of you through the regional coalition. So thanks, Christy, for that recommendation. Very appreciative of that. So without further ado, I'm going to turn it over to Kathy Walker. And you should be able to share your slides, Kathy.
Okay, thank you. And thank you everybody for being here this morning. So the first part of the presentation will be navigating healthcare insurance specific to Medicare and Medicaid and how that works with long-term care. So we have the basics of Medicare, which are your Medicare Part A, B, and then you have C and D, which are additional options.
Kathy, we can't see the presentation.
Oh.
Yeah.
Okay. And
I was just about to say that, and I thought maybe she hasn't started it yet, but.
Okay, nope, I did. And did you set me up as a co-host?
Multiple participants can share, and Lisa, you're not sharing now, right?
No, I'm not.
Okay, all right.
I think you have to say that you want to share your screen though, Kathy, on your end.
Yep, okay.
Yeah.
Got it.
There we go.
Yep, here it comes.
Okay. That's it. There we go.
All right, let me just go back a screen or two. Well, we'll just start from here. Okay, so
perfect.
The basic parts of Medicare are your Medicare Part A, which is your hospitalization. Part B is your medical care for doctors. C is the Advantage plans, which combine your A and B. And D is your drug coverage. The Medigap or the supplemental insurance is totally separate from basic Medicare. So when and where to apply, your Medicare benefits, you can apply at Social Security when you're 65, or if you're disabled and have had disability for 24 months. And when you retire from having employer group coverage. and also for individuals with end-stage renal disease or ALS. And Medicare Part C and D, you apply through Medicare once you have your benefits A and B set up. And each of the coordinators at RRCS can assist with the C and D. This is a slide that just shows your original Medicare, which again is A and B. You can add your Part D, which is your drug coverage, and your supplemental insurance. Or your other option is the Medicare Advantage plan, which they call Part C. And we'll get into that in a little bit more detail. So again, Part A is your inpatient hospital care, your nursing care, home health, and hospice. Part A has typically no premium if you have worked your 40 quarters. And it does have co-payments and a deductible for your hospitalization. Part A also covers your skilled nursing services and rehab. And that would be either at a nursing home that has rehab services or an acute rehab facility. They also have co-payments and co-insurance, and those are listed. It's 0 for your home health with limited coverage, and 20% for your durable medical equipment. The important thing with your skilled nursing and rehab is that you are required to have a 3-day inpatient hospital stay, and observation status doesn't apply to this. You have to be an inpatient at a hospital before you can make use of your skilled nursing services and rehab. Part B, and again, this is just general information, more high level than the details. But your Part B is your general health care. And these are services from providers that accept Medicare benefits. It includes your outpatient care, your medical equipment. There's a host of preventive services, and it also covers emergency room visits. Part B does have a premium, deductibles, and co-payments. The premium this year is $170.10. This does go up with your income. If your income is over, I believe it's $91,000 or $98,000 a year, your basic Medicare Part B premium will increase. The deductible is $233, and co-insurance is 20%. So Medicare will pay 80% of most procedures, and you pay the additional 20%. There is a late enrollment penalty if you don't enroll when you are first eligible. Part D for Medicare is your drug coverage. And the drug coverage is run by private insurance companies that are certified by Medicare. They do have monthly premiums, deductibles, and cost sharing. And the drug coverage is intended to help cover the cost of prescription drugs, but in most cases, it does not cover everything. And you have to be enrolled in Medicare Part A and B to take your drug coverage. And again, there is a late penalty for not applying when you're first eligible. Few key points with your drug coverage. Not all plans cover the same medications. So it is really important to have your drug plans reviewed from year to year. And drug prices may not be the same at different pharmacies. Pharmacies can charge different amounts for the same medication. And the coverage is person specific based on your particular medications. So just because a friend or a relative has a plan that covers more or less than what you pay, doesn't necessarily mean that plan will be the best plan for you. Medicare Part D is part of open enrollment that runs each year from October 15th through December 7th. And the Part D plans, unlike the Medigap plans, are intended to be reviewed, and you can change them from year to year. And again, this is just that overview of Medicare Part A and B as original Medicare, where you can add Part D, and then you can add the Medigap or the supplemental insurance, and then the Medicare Part C, which combines Part A, Part B, and Part D.
Kathy, I just want to interrupt for a minute. There seems to be an echo, so is everybody on mute? Please double check. Thank you. It seems to have stopped. Perfect. Thanks.
Okay. So Medicare Part C are the Medicare Advantage plans. They are run by private companies, and they have to include all of the benefits that Medicare Part A and Part B cover. The private insurance companies are approved by Medicare, and most of them include prescription drug coverage, and again, most will offer additional benefits such as dental, vision, and hearing, and they can charge additional premiums for those options. The Medicare Advantage plans have in-network and some have out-of-network options. The in-network providers will give you a lower cost for your co-payments and your co-insurance, and the out-of-network will be more expensive. And you will pay co-payments and deductibles for most of your doctor visits and your hospital stays. The plans are area specific. So as people see these wonderful commercials on TV that offer everything free and putting money back into your Medicare and Social Security benefit, they are area specific. In our area, there might be a total of 20 plans, and even different between counties. So before anyone switches to an Advantage plan, please make sure that your doctors accept the plan. We can't emphasize that enough. Medigap insurance, also called supplemental insurance, are also private companies, and they are lettered similar to Medicare, so not to confuse the two, but they are lettered. And there are 10 plans that are available. They are offered at age 65 or during your special enrollment period, which would be when someone retires after having worked and had credible insurance through an employer. You have to be enrolled in Medicare Parts A and B. And they also offer what's called a guaranteed issue. And with the guaranteed issue, you can enroll in these plans without any medical underwriting, but you only have that one opportunity, either at age 65 or at retirement, or if you're on disability and then turn 65 after a certain time. Plans cover some of the cost that Medicare doesn't pay, and it just depends on the plan. The comprehensive plans cover your co-insurance, your co-payments, and your deductibles. This chart shows the different plans. Again, they're lettered. And along the left side, and I hope it's not too blurry, are the benefits that are offered. And the check marks just show which plans cover those additional benefits. So if you look at the F plan, that is, or was, because it's no longer offered, unless you were eligible before it closed, that plan covers everything. So you would not have co-insurance for your Medicare Part B. You would not have the Part A deductible, which is, I believe, $1,500. You don't have the Part B deductible to pay, which is $233. And it covers 100% of the Part B excess charges. There is foreign travel and preventive care. The next comprehensive plan is G. And the only thing that doesn't cover is your Part B deductible, which is $233 for this year. So essentially with a Medigap policy, you would pay the premium, you pay your deductible for Part B, and you should have no other out-of-pocket expenses. I just want to talk a little bit about Medicaid. And Medicaid is additional aid, essentially for people with lower income and people that need long-term care, and again, lower income. For Medicaid, you have to apply, you can apply online or at the Department of Social Services. Medicaid is a federal program, but it is state specific. If someone moves from, say, Maryland or Arizona and they come to Virginia, if they had Medicaid in those states, they have to reapply when they come to Virginia. So it's not transferable. It does renew from year to year. And a few years ago, Virginia participated in the Virginia Medicaid expansion, which now covers individuals from ages 19 through 64. Medicaid has income requirements as well as resource requirements. In addition to that, you have functional requirements in order to receive Medicaid benefits. The different types of Medicaid include community-based care that you can receive at home, long-term care at a facility, which would be your nursing coverage. And there's other financial assistance available to help pay for your premiums and deductibles that is part of Medicaid, and they're called Medicare savings programs. Medicaid long-term care, again, community-based care, which is for individuals at home that have Medicaid and have a need for nursing services at home, typically provided by an agency, or it can be consumer directed, where a family member or the individual themselves would hire the aides and work with a facilitating company that takes care of some of the payroll and paperwork. If you have Medicare and Medicaid, you would also be assigned a care coordinator. In the state of Virginia right now, there are 6 companies that manage our Medicaid benefits. And the nursing homes, the only public payer of long-term care is Medicaid, and that would be for a nursing home. Medicaid does not cover services at an assisted living unless you have an auxiliary grant. And the auxiliary grants, finding a facility that accept them, there are very, very few in the state anymore that accept the auxiliary grants. And you would also be assigned a care coordinator, which is an individual that helps navigate your care while you're at a long-term care facility. For private insurance covering long-term care, they are private insurance companies. And you really need to understand your policy that would determine when they pay, where they would pay, and for how long. And the premiums are based pretty much on those factors. Your premiums will increase from year to year. And once you drop that coverage, it's gone. So you really need to understand the details of your long-term care insurance. And that will conclude my portion. Are there any questions?
We've had a few questions come up in the chat. First one is if the slides will be available. I know we're recording this, but are you able to share the slides with folks? You can send them to me if that's okay, and I can send them out.
Yes, yep, we can.
Great. Okay, super. Okay. There's another question in the chat. Does Medicare cover expenses for caregivers?
No. No, Medicare would not cover, well, I guess what expenses for caregivers? And Ursula, I'm happy to talk with you offline about that, but typically Medicare doesn't cover caregiver services. That would be Medicaid for someone that has long-term care services and supports at home.
Okay. I just wanted to confirm that I knew Medicaid would cover it. I just wasn't sure if Medicare did
Right.
as well.
Medicare would cover home health services,
Mhm.
where someone, say they're discharged from a hospital stay and they go home with home health, and that is for a limited duration of time.
Right. Okay. That helps. Thank you.
You're welcome.
Are there other questions for Kathy?
Hey, Kathy. What is Medicare's rationale for the late enrollment penalty? Do you know?
No, I really don't. There is no, there's no practical reason for that, as well as the Part D.
Wow.
You know, making people enroll and saying it's an option isn't really an option.
Yeah.
No, but the late enrollment penalties apply forever.
Wow.
It's not just a one-time penalty. They continue for as long as you have your Medicare benefits.
Thank you.
Kathy, I actually have a question. You were talking about the Medigap. I think that I have been a little bit confused about this. I recently did get in just in time on my 65th birthday. And I did all parts A, B, C, and D. But I'm thinking now that I guess I could have even gotten something else, the Medigap on top of that. But when you showed that chart, it looks like there's only one thing that was covered by Medigap that wasn't included in the supplemental. Is that true?
It depends on the supplemental plan that you take. If you get the Part G, which is now the most comprehensive, the only out-of-pocket expense you'll have in addition to your premium is that Part B deductible of $233. With the Medicare Advantage plans or with just original Medicare, you'll have co-payments and co-insurance to pay.
Gotcha.
And
Thank you.
for your enrollment with Medicare and your supplement, you have 3 months before your birth date and 3 months after. And then there are other special circumstances where you can change plans for your supplement. And it would have to do with whether or not the plan stops. If the company goes out of business, you would have an option to get a new plan. And in some cases, if you move and for some reason that plan's not covered in that area. But otherwise, the supplemental coverage is good anywhere in the United States.
That's great.
Unlike the Advantage plans, they are typically region specific.
There's so much, there's so many layers to this, and this is such a great, clear way of presenting this. So really appreciate this. very much. Are there other questions?
Not so much a question, but a statement to Kathy. Definitely would love to connect with you sooner rather than later so that Marie and I could get you to talk to some of our family caregivers about this. I think the information is needed, and they all fall in that, in this bracket. So I think it would be helpful to have this information presented to them, or what portions of it you can present to them.
Okay.
Awesome.
Okay, so I'm Lisa Dotson, and I'm going to chat just a little bit about care and what care looks like and how we pay for care here in Virginia. And so as Kathy said, you've got your Medicare all set up. You've signed up just like Ellen has, and or maybe you've got private insurance through the company that you work, or maybe even Medicaid. But at some point, and things go along really well, and you don't really use it a lot. Most people don't, except for doctor's visits, until you get a little bit older and you have to have a hospital visit. Something happens, you break a hip, maybe you have a long-term kind of an illness and find yourself in the hospital with a cardiac issue, something like that. So it used to be years ago that, and I can remember at like Culpeper Hospital, because my family's all from Culpeper, and I can remember visiting family that had been in the hospital for 3 or 4 weeks. That was the norm. But as hospital costs have gone up and the cost of healthcare has gone up, things have changed. And so we're going to talk a little bit about that too, and what that looks like. And that kind of feeds into some of the information that Kathy has shared with you. So this first screen, because it is so confusing, and as Ellen said, there's so many layers. This first screen is just really about what the picture, what it looks like. So you're in the hospital, and of course you always have the option to go home directly from the hospital, but many times that's not the best thing to do. And so there are facilities out there that are acute rehab facilities. We're going to talk about those. Skilled nursing facilities, what do those look like? Assisted living, just a straight assisted living, and memory care assisted living, and then home health and what that might look like. So let's see if I can. Okay, so acute rehab. Acute rehab in Virginia is a higher level of rehab than what you typically can receive at a skilled nursing. Typically, you get 3+ hours of therapy per day. And what that translates into is that your stay at the acute rehab is much shorter. People go into the hospital and they don't want to go into facility and stay for 20 days, for 80 days. They want to go home. And so with an acute rehab today, you have that option. If you can do the 3 hours of therapy, you can transition from the hospital into acute rehab, and you can exit and go home in a week, week and a half, maybe 2 weeks tops out of acute rehab. In an acute rehab facilities, there are physicians. You have 24-hour nursing. It's acute, very much like a hospital environment. Your payer sources are Medicare, Medicaid, and private insurance. So your next option would be a skilled nursing facility. And you say, well, Lisa, why would you choose skilled nursing over acute rehab? Well, it may be that based upon your comorbidities, you can't sustain a 3-hour rehab per day regimen. And so at a skilled nursing, it's about an hour a day. It's a level under acute rehab and under your UVAs, your Culpeper Hospital, Fauquier Hospital. But it really butts up to it now. And so they can take at a skilled nursing facility people that, are still pretty sick coming out of the hospital. And so you would stay there for short-term stays, and you can, as Kathy mentioned, this is your option for long-term care, utilizing your Medicaid benefit, or you could pay privately to be in a skilled nursing facility. There's physicians that are on call. Physicians are not typically, they don't have, most facilities do not have a physician that it has an office there in the skilled nursing facilities. They usually come once a week. The nurses, their care for the patients and the rehab staff, and then they report back to the physician, and then he comes in and sees them as needed, typically once a week, maybe twice a week, depending on what's going on. Your payer sources at a skilled nursing facility are Medicaid. As Kathy said, in order to qualify to be in a skilled nursing facility, you have to have had a 3-day hospital stay. The first 20 days, if you qualify for a stay at a skilled nursing facilities, Medicare pays for at 100%. And then from day 21 to 100, they pay at 80%. And you say, well, who pays that other 20%? Well, you either have a supplemental plan, like we shared, or you pay for it. Your secondary insurance, like Kathy had stated, or you pay for that privately. Medicaid can also be used at a skilled nursing facility, private insurance. If you pay privately in a skilled nursing facility, the rate per day is about $250 plus. I have heard of some facilities that are $350, $375. Now rates have gone up considerably in skilled nursing facilities. And where you would see that is in a larger metropolitan area. Okay, so the next level of care that's available in Virginia would be an assisted living. And it used to be that assisted livings that you had to be able to walk to dining, you had to be able to toilet yourself. There were many stipulations about living in an assisted living, but that's really not the truth anymore. Today, most assisted livings can help with all of that. They can assist with all of your, what we call activities of daily living. So dressing, bathing, getting back and forth to dining, all of that, your assisted livings today typically can help with. On site, typically, there's no physician on site, but a physician does come on site, and they typically have RNs, LPNs, CNAs, they have med techs that help to distribute medication, and they have PCA, personal care assistants, and they do a lot of the hands-on care at an assisted living. You can get PT, OT, and speech at an assisted living today as well. Most organizations partner with a provider in the area, and so they're typically there pretty much every day providing those types of services to residents. In an assisted living environment, there typically are activities. The psychosocial benefit of that for people that are older and looking for care, this type of care, is really important. And the activities play a huge role in that there's things to keep them engaged, keep them from a cognitive standpoint thinking and active. There's also typically exercises and things like that. They take trips typically at assisted living. So you may go for a drive out in the country. You may go to a restaurant, you may go to, like we go to Yoder's, to see the animals and eat ice cream and sit on the front porch. Lots of fun things like that assisted livings offer today. Payer sources at assisted living, for the most part, are private pay, and the rates at an assisted living will run anywhere from about $3,400 up. I put a threshold on there of about $7,000, but it can be more expensive depending on the services and the type of facility that it is. Aid and attendance can, which is a veteran benefit, can help. There is a component of veterans benefits that does pay for assisted living. So keep that in mind as you're thinking about assisted living for older folks that at one point in time were veterans. Spouses of veterans can qualify for that as well. Your long-term care insurance, as Kathy mentioned, is another option for folks that have that. That does help to pay for assisted living. And then, of course, we mentioned the auxiliary grant. You don't see a lot of facilities today that will take an auxiliary grant as payment, and that's due to the rate that is assessed for an auxiliary rate and for an auxiliary grant, and facilities just can't afford to function at those levels. So memory care assisted living is a little bit more robust than an assisted living. Again, it's inpatient. Some facilities do offer respite stays. not as many as used to, and folks, assisted livings really can't hold rooms for people. That's kind of a, that's an issue with a respite, but I know that facilities are trying to do more of that for the community because it is so important that caregivers get a rest. Again, physicians are on site, come on site to care for residents, and you've got your caregivers very similar to the assisted living, along with PTOT and speech. Typically in a memory care facility, your staff is trained in how to care for dementia and Alzheimer's residents. That includes things like redirection, what causes behaviors, what types of activities you need to have your residents participating in, abuse, lots of different types of care and training, education that needs to go into how to care for an Alzheimer's dementia patient. Because when the resident admits with you, you become, as the caregiver there in the facility, you become the advocate for the resident because they really cannot tell you what their needs are. So you have to be able to read their body language. You have to be able to know what's the norm for them. And so it's really important that as you look at options for memory care assisted living, that you keep that in mind and you ask those types of questions so that you understand what kind of training is going on and what types of activities and things like that the facility offers. The facilities are typically secured. Payer sources are private pay. They can run anywhere from about $4,200 to about $14,000 again, depending on what services are offered. In larger metropolitan areas like Washington, D.C., there are between $10,000 and $14,000. Same as before with assisted living, aid and attendance, long-term care insurance, and the auxiliary grant. So,
Lisa?
Yes, ma'am.
Sorry, I just wanted to reiterate or reconfirm that's per month you're talking,
Yes,
those
ma'am.
fees.
Yes,
Yeah.
ma'am. Yes, ma'am.
Yeah.
That is per month. And so the next screen that we have here is home health care. Whoops, let me go back. Oh, sorry about that. So home health care is an option that you have when you leave the hospital. If you say, well, I'm going to go straight home, but I need some therapy and I want to do it in my home, or I need some nursing services, that can be arranged for you. And so home health care providers, they have RNs, LPNs, they can set up IVs, they can do lots of different things from a nursing perspective. But they also have a group of folks that can help with PTOT and speech many times. And so these services are provided in your home. They're usually short term, and people get really confused about this because they think, oh, I'm going to go home instead of going, for example, to a skilled nursing or maybe even an acute rehab, and I can get the same level of service at home that I can in these other facilities. And that's really not the case, because the care that's provided is paid for through your Medicare, and they will only allow for a certain number of visits per week. And so you're not going to get the same level of care that you would have, like, for example, in a skilled nursing facility where you would have around the clock 24-hour care. And people get really frustrated with that because they say, I thought they were going to come and visit me and they only came once a week. Well, that's what that particular level of care covers and what Medicare will pay for. So your Medicare is your payer source, Medicaid, private insurance, long-term care, and aid and attendance pays for that as well. And then you have home care, and this is where it gets really confusing. So your home health care, with the word health in it, offers a different level of care. People that can come in and do some care, some clinical care, like your nurses can come in and do things like that, and your PTOT and speech people. But where it pertains, as it pertains to home care, that's really where someone is coming in, and they may be a CNA or they may be a personal care assistant, but they're just really coming in and they're helping with things in the home. They're giving you reminders about your medication. They're making sure that your loved one gets a bath and eats, monitors that for you. They may do some light housekeeping for you as well. This is typically private pay, but again, there's some other ways to pay for that through the veterans, and some long-term care insurances will help with that. So we want to just touch on palliative care and what that looks like. People, when you move away from hospital care and facility care and home care, and you start talking about palliative, and you start talking about hospice, people get really antsy. So we want to talk about that. They don't really understand it. But it's really changed in the last probably 10 or 15 years. So today we have medications and devices that can be implanted in us and can monitor us so that we can live a lot longer. And so many people have life-limiting illnesses, but live for many, many years. And those illnesses can include things like heart disease and cancer and ALS and COPD, lots of different types of things out there. But they can live long, healthy lives. I mean, a lot longer than they used to in the past. So what palliative care does is it focuses on your plan, on the plan of care, and it really focuses on how to do it in a very holistic way. What is the best quality of life that my loved one can have for the life that they have left based upon, the illness that they have? Because many of these, like cancer, eventually cancer, people will pass from cancer, just like Alzheimer's and dementia. People, will eventually pass. But what is that life? What does that need? What could that look like? And what do we need to focus on? And so the goal is really there to improve the quality of life. And there's many organizations out there now that offer this type of a service. And so I would encourage you to look at that if that ever presents as an option for care for your loved one. And then let's talk about hospice. This is another level of care that people don't like to talk about. People don't ever want to talk about hospice. But the reality is that all of us at one point in time will pass. Typically with hospice, Medicare pays for some of the hospice benefits. Typically your life expectancy is 6 months or less, but I have to tell you, like in a facility, that can be a whole lot longer, and you don't really get pushback from Medicare about paying for that at all. So hospice can actually enhance people's lives in such a way that they do live longer because they're getting a little bit more care. They're getting some of the attention, especially like in home, that they maybe weren't getting before. So it focuses on comfort and pain and emotional support. Typically you have pastors that are associated to hospice organizations, and you have social workers and people like that that can come in and can work with the patient and with the family. Some medications are provided by hospice, so do not have to be paid for by the family, and then incontinence supplies as well. And then medical equipment, and that's a really big one, like, for example, a hospital bed and wheelchairs and walkers and things like that. And your payer source for hospice care is Medicare, Medicaid, private, and private insurance. And so that's it. That kind of wraps up our presentation. Did anybody have any questions for me about anything?
Thank you, Lisa. I think we have a couple in the chat. Oh,
Okay.
well, the titles for each one will be on the slides. Lisa, what was the title of yours? I'm sorry. It's probably on the first slide.
It is on we just kind of rolled it all together from a, let's see, if we go back, let's see, what do we have on here? What did Kathy put on here? Navigating health insurance and long-term care options.
Okay, thanks. Thank you.
Mhm.
There's a question from Ursula. You mentioned physicians on call. How is the PCP involved in these various out-of-home options?
Residents can maintain their relationship with their primary care physician if they want to do that. But what we find more often than not is because families are so busy, living their lives, working, things like that, that it's really better to work with the physician that services the facility. And I think any assisted living, to be honest with you, I think any family that's worked with an assisted living would tell you that that is so much better, because what happens is then you're no longer the middleman in any issue, anything that happens. Now that conversation goes from the nurse directly to the doctor, and it happens very quickly. And so with regard to medications or hospitalizations or things like that, it's a much quicker response than waiting for you or your doctor to get back in touch with the facility. Where a physician isn't necessarily linked to a facility like that, they're not as quick to respond. And that's just normal. I mean, that's just the way it is, but you definitely want your loved one to get that kind of a response and that type of care. And so typically, I will tell you that assisted livings have great physicians. They're typically geriatric care physicians in the community that, like, for example, I know Annette's got, great physicians there at her facility, people that have been working in the community for years. And we have like one of the doctors for ours has been with us for 19 years, and he's a geriatric provider. So it's typically best to utilize those physicians. And with your medications, the cost of medication has gotten so complex. And that's why Kathy is recommending that everyone review your medication, the Part D of your Medicare, on a regular basis, because the pricing changes, and it has gotten so complicated that our pharmacy now will work with just about any provider mail-in service, and you just mail into the pharmacy because they have to package it a certain way in assisted livings. But they really work hard, most of the pharmacies that I've dealt with in Virginia, to work with different providers and different ways that folks secure even VA medications. The pharmacies will work with to get them packaged properly and then shipped back to the facilities.
Yeah, I think you made a really good point there, Lisa, in terms of geriatric physicians. A lot of people don't realize that there are so many specific types of medications. There's so many specific issues with aging and medication for older adults that are very different for younger adults. And it really does take that specialty. So I think being in the care of a geriatric physician that's a really good point that you're making with that. There's please, can you go back to the palliative slide? Request.
Sure.
Okay, and then is there a question? That's Rosella Ann. Thank you, she said. Maybe just wanted to look at it. Okay. All right, yes.
Okay.
So those were the chat questions. Are there other questions or comments for Lisa?
Hi, it's Lola. I just want to thank both Kathy and Lisa, because you put this in such simple language. I do supervise 5 senior centers, and we are getting projectors and screens this year, so we'll be able to do Zoom and things like that. And I'd love to have you guys present this at our senior center sometime soon, after I get my new equipment. We're excited. Thanks again.
Yes. Yeah, it's it's a very complicated topic, and you both presented it in such easy to understand language. So really appreciate that. We have recorded this session, and all being well with technology, it will be available on our website. Our presenters have agreed to share the slides as well. So yes, another comment, excellent presentations. So thank you so much. We're going to hang on you if you want to stop your share. We'll come back to the group, and we'll hear from folks for any updates, but thank you both so much. Just excellent. And I think I'll go ahead and stop the recording now.